Welcome to the Geneva Association Health and Aging Conference 2020. It is a virtual conference, as most conferences are, so thank you very, very much for joining. My name is Ronnie Klein, and I'm a collaborating expert on health and aging for the Geneva Association. And we have a great lineup for you today. So first, I just wanted to go quickly through the agenda, which you should see up on your screen right now. So after a few addresses, we will get into the meat of the sessions. We have 2 sessions today and 2 equally as good sessions tomorrow. For the first session, we will talk about longevity and the impact of COVID-19, especially on the elderly population. This is a big question on everyone's minds, and we have top experts talking about this. And then the second session, we'll be talking about connecting the physical, mental, and financial well-being. As you know, being locked down during COVID-19, it doesn't only affect our financial well-being, but it also affects us physically and mentally. So we'll be talking about that. Tomorrow, we'll be talking about healthy aging to move from reactive to proactive. And then finally, in the last session, we have our view from above, where we have 2 top CEOs discussing the insurance industry. So we have a really, really great program for you. The next thing I'd like to discuss are a few house rules first. The first thing is, on your screen, you're used to Zoom calls, but you will not have the ability to turn on your mics. You will not have the ability to turn on your video. So we won't see you, you see us, but we won't see you. The only thing that you do have access to are these 2 features. You have the raise the hand access, and you also have the question and answer access in this chat. So please, if you do have a question, we would prefer that you use the question and answer, write it down in the Q&A box, and please send it to either all speakers or everyone. And this way we can all see it, and we can sort these out in relevance, and then I can ask the questions. At the end of both speakers, so we have 2 speakers in the first group, at the end of, well, actually 3 speakers, at the end of all 3 presentations, that's when we will work on the questions and answers, but you can send them in at any time. If you'd like to raise your hand, we may call on you and then unmute you, and you'll be able to ask your question. And of course, if you need to use the restrooms, they're down the hall. The men's room is on the left, and the women's room is on the right. So you don't have to worry about the restrooms. You can use your own. And now, I would like to move to to kick off our session, the Managing Director of the Geneva Association, Jad Aris. Jad just took over this position in March of last year. And Jad, I'm sure that you were not prepared for this pandemic that came about. But I have to say, the Geneva Association not only strengthened its resources and personnel during Jad's tenure, but also refreshed the research programs and increased membership. The conferences had to move to virtual conferences. As many of you know, the Geneva Association prides itself on in-person conferences. The team had to, under Jad's leadership, had to move to a completely different venue, as many organizations did. And already Jad has left an indelible mark on this organization and done just a fabulous job. I'd like to know, Jad, if you would have taken the position had you known this pandemic was coming with an organization like this. But Jad, it would be our honor if you can kick off the 2020 conference. Thank you.
Thank you, Ronnie, for these kind words. Welcome. First of all, good morning, good afternoon, and good evening to all of you to what is actually the first virtual health and aging conference of the Geneva Association. I first want to extend my wishes to each one of you participating to this conference, my wishes of good health for yourselves, for your families, and for your colleagues. This event was initially meant to take place physically in New York, kindly hosted by Prudential Financial, a member of the Geneva Association. Of course, the pandemic has led us, as Ronnie reminded us, to change our plans, to move to virtual for this event and for all other Geneva Association events likewise. Some of you were probably participating to our conference last year, which took place in Toronto, Canada. And those who were there may remember that we had at that point shared the fact that we were repositioning what had been the long-standing aging research workstream of the Geneva Association to health and aging. Well, this could not have been more timely. And to answer your question, Ronnie, yes, I would have taken the role while knowing that the pandemic is going to come, because we're actually even more equipped now to tackle these issues. The topic of health has never been more at the forefront of our minds than it is now. We are not only trying to stay away from the virus, but all of us, I believe, we are today more conscious, more aware of our deeper health status, as underlying health conditions such as obesity or diabetes or respiratory issues make us more susceptible to COVID-19. Aging is also a vulnerability factor. There is a lot that doctors and scientists still have to learn about COVID-19, but from the outset, it was very clear that the virus was affecting more severely the elderly. Nursing homes had to close to visitors, cutting senior residents off from their loved ones during scary times. Health issues, physical health issues, but also mental health issues, whether due to government restrictions or to personal decisions. We have all done a lot less socializing than normal this year, whereas social interactions could have been actually a relief for extraordinary stresses like unemployment due to the economic crisis, or parents juggling homeschooling with their professional work at home. These changes have brought unwelcome isolation for many and have compounded a physical health crisis with a mental health crisis as well. And we will also be deep diving into this later during the conference. So how is the virus and its social and economic impacts affecting insurers? Well, in this gloomy picture, there are some good news. The first one is that the insurance industry has actually proven very resilient in the current crisis. And there are probably two reasons for that. The first one is the swift and massive response from governments and central banks to the crisis, a response that has been swifter and more massive than in the previous 2008 financial crisis. But the second reason is certainly the sound risk management practices which insurers have developed over time, particularly in the past 10 to 15 years after the 2008 financial crisis. Risk management practices on their liability side, their underwriting sides, and also on their asset side in their investment practices. Well, this is very important. The fact that the insurance industry has proven to be quite resilient in the crisis means that insurers have been able to play fully their role of supporting and protecting their customers in these difficult times, supporting and protecting their customers by making their health insurance benefits and life insurance benefits available to them. Today is actually a special day. We are releasing at the Geneva Association the first report of a series of reports focusing on the consequences of the pandemic on the insurance industry. And the report, which got issued literally today, a few minutes ago, focuses precisely on that, on the insurability of the pandemic. Let me stop here at this point. Let me renew my thanks to Prudential Financial, who are co-organizing this event with us. And let me hand it over back to Ronnie. I wish you a very exciting and fruitful Health and Aging Conference 2020. Thank you. Ronnie, back
Thanks
to
so
you.
much, Jad, for those inspiring words. A lot of you may not know that Jad began his career at McKinsey and then spent a long time at AXA. So he's a real insurance expert, and even came up with this cool tagline behind me, Insurance for a Better World, which I think says it all about the Geneva Association. So thanks again, Jad, for those great words and for kicking off our conference. I really appreciate that. Next up, we have our keynote address. And as Jad said, Prudential is sponsoring this conference. One of the bad things I think about the virtual conference is I know that some of the people we work very closely with at Prudential to put on the conference, especially Amy Kessler, who's on the line now, said that the one thing that she was really upset about is she didn't get to host all the people, at Prudential. So she has agreed to cook for everybody. So anybody who wants food, just go right over to Amy's house and she will cook for you. I'll send you the address soon. So Amy said she'd be happy to do that. So now our keynote address is from Janella Frias. Janella, it's hard to keep up with your titles because you are a rising star within Prudential. I've known you for a few years and you just keep rising through the ranks. So for those of you who don't know Janella, please keep an eye on her because she is really a rising star in the insurance industry and you should get to know her if you don't. She's currently the president of Prudential Retirement, managing over $500 billion of assets, Prudential is pretty much a retirement company. So Janella, I'm not sure why you're just not CEO of the entire company, but I won't tell Charlie that tomorrow. So Janella is president of retirement. And before that, you were in charge of this also very important part of Prudential, and actually many companies, is the pension risk transfer business, which is really exciting. So Janella, I'm very excited to hear your keynote remarks, and I'll turn it over to you. Thank you very much again for hosting.
Thank you, Ronnie, and good morning, good afternoon, and good evening, everyone. It is wonderful to be here with all of you today. And Ronnie, thank you for the kind words. Let's not tell Charlie you said what you said about the CEO of the company. We at Prudential, my colleagues and I, we're so looking forward to hosting all of you at our beautiful Prudential Tower in Newark, New Jersey. But, like everything else and everyone else, we're pivoting. And we're very happy to be here and to have this virtual event. And really, so welcome to all of you. It'll be a great conference. Now, as you've already heard this morning, this year has been nothing that anyone expected or could have predicted. Our world has shifted from certainty to uncertainty in pretty much every aspect of our lives, our health and well-being, our work, our families, our economy, and our society. And we continue to navigate these many risks and far-reaching impacts of a global pandemic. We don't know with certainty what the future will look like, and it is unclear in this current environment what will be temporary or what will be permanent. And that ambiguity isn't only the result of the pandemic. The headlines of racial injustice across the United States have very much shined an international spotlight on systemic racism in this nation. So I would like to acknowledge everyone who has demanded racial justice and equality in this country and around the world, especially in these past few months. At Prudential, we are committed to driving inclusion and diversity and eliminating any barriers that have limited people of color from attaining financial equity and security. We view that as a very important part of who we are. I think it is important to start with acknowledging that nearly every aspect of well-being of Americans and citizens around the world is being challenged by what we're experiencing, from the pandemic, from the loss of loved ones and livelihoods, from the need to socially distance, and from the outpouring of grief and anger resulting from the recent examples of racial bias and violence. And this is enormously stressful, physically, mentally, emotionally, and financially. Now, to be clear, prior to the pandemic, we already had an evolving crisis. 2/3 of Americans were living paycheck to paycheck. 60% didn't have enough money for a $500 emergency, and over half of workers in the US had zero retirement savings. With a growing aging population in the world's largest economies, the retirement savings gap stood at $70 trillion in 2015. That is according to the World Economic Forum. And this retirement savings gap is projected to grow to $400 trillion by 2050 if measures are not taken to increase overall levels of savings. And now add to that the economic impact of this pandemic, which could be staggering, and it will not affect all walks of life equally. We already see that COVID is affecting a disproportionate number of Black and Hispanic lives. An opinion piece in the New York Times in early August showed that white Americans died at a rate of 89 per 100,000 in 2018, and are projected to die at a rate of 92.5 per 100,000 during the pandemic. But health departments in cities across the United States have reported that Black people are 3 times as likely to contract the virus, 6 times as likely to be hospitalized with the virus, and twice as likely to die from the virus. And data from the Office of the National Statistics found similar disparities in England and Wales, with Black people being twice as likely to die than white people after taking into account age, measures of self-reported health and disability, and other socioeconomic and demographic characteristics. This gap in Black and white infection and death rates is due to structural inequity that is absolutely a matter of life and death, as we're seeing during this pandemic. Today, people of color continue to be far more likely than white people to work jobs that limit their ability to quarantine, live in overcrowded housing, live closer to environmental hazards, have limited access to healthcare, and be underrepresented among physicians. This is not acceptable. Better financial and physical health should be and must be within reach for everyone, regardless of race, background, or socioeconomic class. These are long-standing issues that need bold solutions in both the public and the private sector in order to drive real and lasting change. As a global financial services organization, we at Prudential believe that we have a responsibility to build solutions that serve people around the world. In the US, Prudential has partnered with many organizations focused on financial wellness. Organizations like Prosperity Now and the Financial Health Network. And we've done this for many years. And we share a focus on broadening people's views of the factors and policies that affect financial health. More recently, we have partnered with the Financial Solutions Lab, which is an arm of the Financial Health Network, because we've been very impressed by their work, including the lab's success in producing consumer insights, accelerating cross-sector collaboration, and scaling financial solutions for underserved communities. The Financial Solutions Lab gets much needed capital into the hands of startups led by people from different backgrounds, ethnicities, and genders. And this allows them to fund and scale solutions for low to moderate income people and further its combined reach and impact. Given the growing economic inequalities, which are made even more apparent and severe by the pandemic, we all need to increase focus on equipping historically underserved communities and individuals with the tools and support they need to get on a path to economic and social mobility. Now, let me spend a few minutes on the role of the employer and things that workers should be taking advantage of from their holistic workplace benefit programs. Employer-sponsored retirement savings plans are a major component of many countries' retirement systems, in addition to other government programs. But many individuals, such as gig workers, those who are self-employed, and those who work for small businesses, do not have access to these employer-sponsored plans. To address this gap, many in the US, including Prudential, have been advocating for solutions that increase access to retirement savings plans by making it possible for smaller employees to band together to offer a retirement savings plan that they could not have otherwise offered on their own. Now, we know that some countries like the UK mandate employers, regardless of size, to enroll their employees in a defined contribution retirement plan. And that has yielded very positive results. About 90% of workers at medium and large companies in the UK are now contributing to a retirement plan. And 70% are contributing at small employers. On the other hand, only about 50% of Americans in the private workforce are participating in a workplace retirement plan. So think about that, 90% or 70 at small employers in the UK versus 50% in the US. Now we're starting to see progress in the US with the passing of the Secure Act, which makes it much more possible to offer multiple employer plans, but it is still early days. And surely there's much more to be done to expand access to employer-sponsored plans in the US and in many other countries. And there's good reason to do so. Not only to increase the overall savings rates, but to increase the overall financial wellness of workers at all income levels. Now, well before COVID, employers around the world had started to embrace the idea of offering more financial wellness tools and resources to their workers as part of a holistic benefits program. And that's because as an industry, we know that people need help with their finances. Figuring out how to save for the future when you also have short-term obstacles like debt or health-related expenses is not easy. And if an individual is not financially well throughout the journey and cannot handle their short-term needs, they will not be able to save for their long-term retirement goals. Now, we believe at Prudential that the workplace is the best place to build people's confidence and familiarity with their financial options, as well as to help develop positive habits and behaviors for budgeting, debt management, and saving. And this is for a few reasons. First, the workplace has always been where many individuals' financial lives come together. It is where they're safe for retirement, where they fund their healthcare expenses, and in many cases obtain insurance. Second, employer-sponsored benefits programs provide many opportunities to engage individuals in discussions about their goals all year round, as well as at critical life events like marriage or the birth of a child, and also when something unexpected happens and they need help with a disability claim or a hardship withdrawal from their retirement plan. And third, our research shows that 76% of people say they trust their employers, well ahead of the trust they have in any other institutions like the government, the news media, or business in general. Employers have a vested interest in helping their employees with financial education and tools, because research shows that workers are much more likely to stay with employers who offer financial wellness programs. And if workers are less stressed about their finances, that can have a very positive impact on their productivity at work and on their overall health. As an industry, we owe it to our society to provide the tools and education that help all get on the path to holistic well-being and to remain on that path. And mental health is also a concern now more than ever. It is important to recognize the anxiety and isolation so many are feeling right now, and how that leads to feelings of frustration, anger, which could interfere with decision-making and really everyday well-being. Fear, anger, isolation, feeling irritable, feeling anxious, all of that is normal. And we have to be able to have those conversations in the workplace. Employers must be trained to be sensitive to the deeper issues at play here and not make the mistake of mental issues being mistaken for lapses in performance. We need to raise awareness, minimize stigma, and increase access to care so that we can have people get the help that they need. Now, while people often feel comfortable discussing physical ailments and encouraged to take time off from work to treat them, 2/3 of employees hide their mental health condition at work because of fear and the stigma that comes with that. And COVID has presented unique challenges to mental health, but if we provide employees with the space to discuss and normalize their feelings, that can push them towards the help and support they need. Mental health issues, both in the US and globally, will likely last well beyond the pandemic. By 2030, we expect that depression will be the #1 cause of lost productivity in all economically advanced countries. Now, many employers have support programs and counseling available to help employees and their families cope with what's happening. And those services can be very valuable to mental and emotional well-being. In addition to counseling programs, many employers offer programs for stress reduction, addiction recovery, and healthy lifestyles. And those programs can help many people stay positive and focus on their well-being. Now, the pandemic appears to be the top contributor to mental and emotional stress right now, which makes sense. Now, the pandemic is followed by financial issues and the economy as adding to emotional stress. Now, among those who are highly stressed, money is the most common cited contributor, suggesting a relationship between mental health and financial stress. And this is probably not news to those on this conference. Now, with regards to the workplace, I also believe the workplace will be very different coming out of this crisis. For example, we will likely see more physical distancing inside work sites or time shifting when employees are in the work site or not. And we've all gotten much more comfortable with technology and virtual engagement. Think about what we've experienced with remote learning for our children, news anchors broadcasting from their homes, and just even how we're conducting this conference. I think we will see more virtual meetings and training sessions in the future, even in workplace settings. Now, what we have experienced this year makes financial wellness even more important. And I know the employers we speak with every day are looking for new ways to shape their benefits programs to help workers through these kinds of shock when they happen again in the future. For example, there is much more talk of adding budgeting help, debt counseling, and emergency savings features to retirement plans, which will help build that holistic wellness foundation that I talked about earlier. And that's because there's great focus on how we can better educate individuals about the importance of balancing their short-term needs with their long-term financial security. We know many individuals are making tough decisions and trade-offs to get through the crisis. But with better financial literacy and more innovative products and solutions, we could make it possible for people to keep their long-term savings in place for the future. Again, in many ways, the pandemic has underscored the importance and the need to provide individuals with education and retirement plan futures that allow them to build emergency savings, to learn about budgeting and managing debt, and to build a steady stream of income in retirement. So I will close by saying that I very much believe that we will get through this crisis and be stronger in many ways for what we've been through. However, coming out of this crisis, we must do our part to help people feel more secure today while still focusing on tomorrow. Because it's not a matter of if another crisis happens, it's a matter of when. Healthy living, social engagement, and financial security are intertwined. An improvement in even one domain, such as financial security, can help people live longer, healthier lives. Employers, financial advisors, and policymakers can each play a role and should each play a role. Employers can create financial wellness programs that educate individuals on changing their behaviors to make wise financial decisions early on and throughout their careers. Financial advisors can take a broader, more holistic approach to a client's well-being, developing short and long-term plans and starting the conversation early. And policymakers can help by passing legislation that increases access to retirement plans. Access is very, very important. The financial challenges facing economies, families, and individuals are substantial, but they are not insurmountable. If we continue our concerted efforts by all who have a stake in this issue, individuals, employers, financial advisors, and policymakers, we can help societies improve their financial wellness and better enjoy their increased longevity. So thank you for being here today. Thank you for having me. I hope you enjoy the rest of the conference. I know it will be terrific, and have a wonderful day.
Thanks so much, Janella, for that very, very important message. As you may know in our discussions, I also think financial literacy is just so important to get those messages across. And again, thanks for talking about the tough topics that, quite frankly, many people just don't like to talk about. Before we move on to our next session, I just want to say a couple of things. First, I know all of you in the room are thinking about this. When was the last time I was wearing a tie? And the answer is March 4th was the last time I was wearing a tie. And the second thing is, you may see me looking down every once in a while, and the support team here at the Geneva Association, it continues to yell at me. The camera is quite high, and the screen that I'm looking at so I can see what's going on is a little bit lower, and I tend to look at the screen as we do on our laptops. So I'll get used to the technology, so please bear with me. So again, Janella, thank you so much, and thanks again to Prudential for sponsoring this conference. And again, we wish we could have done it in person, but I do look forward to seeing you at the next time I am able to fly to Newark at some point in my life. So now we move to session one. Session one, you will see on here, is called Understanding Longevity Today and the Impact of COVID-19 on the Elderly Population. We have 3 speakers. It's going to be broken up actually into 2 presentations. I will introduce all 3 of the speakers right now. You see their pictures on the screen. So first we have Richard Jackson. He will speak first for about 20 minutes, and he's the president of the Global Aging Institute. I'd like to think that Richard feels the same way about me, that we've become friendly over the last couple of years. Richard is just just a great expert on aging. He's the co-founder of this Global Aging Institute. And actually, I don't know how many of you are like me and getting tired of the word millennials. If you are tired of that word millennials and everything that's going on, blame Richard, because Richard's colleague was actually the one in a book who came up with that term millennials, Neil Howe. So you can call Richard, that's Richard's colleague at the Global Aging Institute, and blame him. It's his fault. Richard's going to talk about some very interesting things. So as our lifespans are increasing, our health spans increasing as well. And there are a couple of conflicting models that talk about this, the compression of morbidity or the failure of success models. And Richard's going to talk about that very, very interesting presentation. After Richard, I'll come back on for a second and reintroduce David Blake and Andrew Cairns. David Blake is the professor of pension economics at the Cass Business School in London. You may not know that actually in Europe we switched our clocks last night, so we're all offbeat here. So David and Andrew are 1 hour behind, and in New York or in Washington, Richard is 5 hours behind, not the normal 6. Anyway, also world known as far as I'm concerned in this field of pension economics. David Blake has worked with Life Metrics with JP Morgan and Towers Watson, and he's very, very well published. Andrew is the professor of actuarial science at the Heriot-Watt University in Edinburgh. And he was elected just recently, was it like a year or 2 ago, a fellow with the Royal Society of Edinburgh I think it's in 2016, a couple of years ago. And he's just absolutely a world-renowned expert in modeling of longevity risk. So David will take the stage first. He'll go for a couple of slides, the bulk of the presentation. Oh, sorry. First, we have Richard. Richard will come up for about 20 minutes, and then we'll move over to David and Andrew. We will take questions at the end. Please use your question and answer forum, or you can wait to the end to raise your hand, but please use the question and answers. We will monitor those, and I will ask those questions at the very end. But we won't take questions till the very end. So Richard, my good friend, please take it over.
Yeah, thanks, Ronnie. I assume you're going to bring up my presentation at some point. Will the screen be shared?
Yeah. So.
Yeah. Perfect. You know, with all the attention paid to the aging of society in recent years, the layman might be forgiven for thinking that there's some consensus among experts about how much life expectancy is likely to rise in the future. I think it's fair to say that virtually all experts believe that it will continue to rise, but there is a very significant disagreement about how much. The layman might also be forgiven for understanding that experts have some consensus view, some handle on whether health expectancy is likely to rise along with life expectancy. You know, there's all this talk about about 60 being the new 40, perhaps in the future 80 might even be the new 60. But is this actually what's happening? If you could bring up the next slide, Ronnie. I'm going to spend just a few moments talking about divergent views on the future of life expectancy, and then segue to the real topic of my presentation, which is the relationship between aging and health, and this vastly important question of whether health spans are indeed rising along with lifespans. I think it's fair. This is a bit of an oversimplification, and maybe I'm recalling here the good, the bad, and the ugly. But I think we can divide views into three camps on life expectancy: the pessimists, the optimists, and the visionaries. The pessimists, and this includes many actuaries, no one speaking on this panel, I think, but the pessimists start from the premise that there's a fixed limit to the human lifespan, generally assumed to be, around 105 or 110. And that as life expectancy rises and more people bump up against the limit, that improvements in life expectancy will necessarily slow. The technical term for this is the rectangularization of the survival curve. The optimists, which include many, if not most, demographers, notably James Vopel, argue that there really isn't much evidence for this fixity thesis. If there really were a fixed limit to the human lifespan, we'd expect a couple of things to be happening. First of all, we would expect improvements in mortality rates at the very oldest ages, say 100 to 105 or 95 to 100, to be slowing relative to improvements at somewhat younger ages. Secondly, we would expect differences in life expectancy across countries, across regions, across different socioeconomic groups to be narrowing, but none of this appears to be happening. Everywhere, or at least almost everywhere, the United States is an embarrassing exception in which life expectancy hasn't risen and indeed has fallen slightly over the past decade. But almost everywhere, people are living longer, and almost everywhere, some people are still living longer than others. Finally, we get to the visionaries, Aubrey de Grey, and others who argue that biomedicine is about to unlock the secrets of the aging process itself, perhaps even ushering in a brave new world of post-mortal societies. Where I stand in the spectrum is a bit besides the point, but I'll avow to counting myself at the least among the optimists. Ronnie, if we could bring up the next slide. We'll So life expectancy is rising, though experts agree about how much. What about health expectancy? There are two very different models of aging and health. The best known is usually called the compression of morbidity model. And it holds that lifespans are rising at least as fast. That health spans are rising at least as fast, in fact, faster than lifespans. And that eventually most of the ills of old age will be confined to a relatively brief period of declining vigor at the very end of life. To put it in more popular terms, we'll all live to 100 or 105 and then die of a cold. The competing model, sometimes called the failure of success model, says that this isn't at all what's happening. Modern medicine, the principal effect of modern medicine is to reduce mortality rates, but it isn't restoring people to full health. In effect, to use the technical term, we're increasing the number of marginal survivors in the population. So the failure of success school of thought predicts that as lifespans rise, so too will age-specific rates of chronic morbidity and disability. Clearly, which model is correct is vastly consequential for our aging societies. We know that one thing that aging societies need to do is to extend work lives and to promote productive aging. Well, how healthy the elderly are clearly has an important impact on the ability of societies to do that. Another thing we know that aging societies need to do is to limit the growth in healthcare spending, which otherwise threatens to overwhelm public budgets. Once again, the health of the elderly could have a critically important effect on the future course of healthcare spending. So if we could bring up the next slide now, Ronnie, thank you. Just a word about the importance of extending work lives. Across the developed world, working age populations will be growing more slowly, or in many countries, in Japan and some of the faster aging continental European countries, they'll be contracting in the future as large post-war generations retire and the relatively smaller generations born subsequently take their place. You can see actually in the top table on the right hand that the slowdown is really quite dramatic, from between 1% and 2% per year back in the 1980s in most developed countries, down in the best case in the United States, Canada, France, the UK, to 0. And in the faster aging countries, the working age population actually contracting by between 1% and 1.5% per year by the 2030s. All other things being equal, slower growth in the working age population will translate through into slower growth in employment, which in turn will translate through into slower growth in GDP. There are a number of things that countries can do to offset the demographic drag on economic growth. They can increase immigration, for instance, but quantitatively, nothing is likely to have a larger impact than increasing labor force participation at older ages, which in most countries falls off pretty steeply, starting in the late 50s and early 60s. We calculated at GAI, excuse me, that in the United States, if adults aged 60 to 74 were, after adjusting for the higher incidence of disability at older ages, to work at the same rate as prime age adults, 25 to 54, it would add 15% to GDP by the middle of the century. Next slide, Ronnie, please. Now, the relationship between aging and healthcare spending is pretty obvious intuitively. Nonetheless, I think it might be instructive to decompose the relationship into what I call the 4 age-related healthcare multipliers. You know, as the rich world and now the emerging world following it moves through the epidemiological transition, chronic diseases, the current pandemic being an unwelcome reversion to an earlier time when infectious diseases dominated, but chronic diseases come to dominate morbidity, and chronic diseases are more common at older ages. Hence, older people consume more in healthcare services than younger people do. In the United States, the per capita ratio of acute care spending by the elderly relative to spending by the non-elderly is 3 to 1. For long-term care, it's a staggering 20 to 1. So that's multiplier 1. We can go through these pretty quickly. Multiplier 2. The next slide, please, Ronnie. So the elderly consume more healthcare services than the non-elderly. The elderly, of course, are the fastest growing segment of the population. Younger child populations and younger adult populations will be stagnating or contracting in the developed world, but the elderly population will continue to grow. Next slide, please. The older the elderly are, the more healthcare they consume. So the ratio of acute care spending by the young elderly, 65 to 84, is not nearly as high relative to spending by the non-elderly as spending by the elderly 85 and over is. And on the right-hand chart, you can see that the spending profile at the oldest ages rises much more steeply, as one would expect for long-term care. Next slide. And finally, just to close out the multipliers, the oldest elderly age brackets are, of course, the fastest growing of all, a phenomenon sometimes called the aging of the aged. Next slide. So let me start by making the case for optimism. The share of the US elderly, we have pretty good data for the US going back to at least the 1980s. The share of the elderly who are disabled has fallen sharply over the past few decades. In fact, as you can see in the chart, by about a quarter. According to data on healthy life expectancy, which is really a measure of disability-free life expectancy compiled by the WHO, and there's similar data sets compiled by the European Commission and the OECD. Healthy life expectancy has also been rising across every developed country, and in fact, in virtually every developed country, healthy life expectancy, again, disability-free life expectancy, has been rising faster at older ages than total life expectancy. All of which would seem to suggest that a compression of morbidity is indeed underway. And this would have positive implications for the ability to extend work lives. And it might also, some optimists, notably, I think it's Kenneth, but Manton at Duke University have argued, might also mean that current projections of healthcare spending based on today's age differentials in spending might vastly overestimate the future healthcare cost burden. Next slide. This is an attractive reading of the data, and I think there is some truth to it, but it needs to come with a couple of big caveats. And the first caveat is that past trends in disability may not be a good predictor of future trends. This is the age bracket fallacy in demography. If you want to know what the health of 75-year-olds is going to look like 20 years from now, you're tempted to look at the health of 75-year-olds today and extrapolate some trend. But what you should be looking at is the health of 55-year-olds today, and then follow them along the cohort diagonal. And if you look at the health of 55-year-olds today, particularly in the United States, but also increasingly in a number of other developed countries, the trends are worrisome. Adverse lifestyle choices, obesity, substance abuse are putting a rising share of the population in the United States, especially in midlife, but increasingly even at younger ages, at a growing risk of premature morbidity, disability, and death. So if the health of midlife and younger adults continues to deteriorate, the downward trend in elderly disability that we've experienced over the past few decades could stall or even reverse. And indeed, at least in the United States, there's some evidence that that's already happening. Next slide. The second caveat, and this is a big one, is that less disability does not necessarily mean less morbidity. Disability is measured by limitations on activities of daily living, such as the ability to dress or feed oneself, ADLs, or on limitations on what are called instrumental activities of daily living, such as the ability to shop or to manage finances. It's entirely possible that measured disability, in other words, the functional health of the elderly, could be improving even as morbidity is flat or rising. So a divergence between functional health and underlying health. And indeed, in the United States and a number of other countries, this appears to describe what's actually happening. Rates of age-specific rates of chronic morbidity for most of the ailments that afflict the elderly are not declining in tandem with the decline in rates of measured disability. So rather than a compression of morbidity, it would seem that what we have underway is a compression of disability. And this brings us back to the healthcare cost issue. The optimists argue that declining disability rates should lower the rate of growth in healthcare spending. But it's entirely possible that the causal relationship is just the opposite. Maybe it's because we're spending so much per capita on the elderly that disability rates are falling. Grandma may be getting around better, but maybe she's getting around better because she's taking her pills and seeing her doctor as often or even more often than before. Next slide. The final caveat is that other cost drivers may be as important or perhaps even more important than the health of the elderly. You know, if falling disability rates at older ages really did portend slower healthcare growth, well, remember, disability at older ages has been falling for the past few decades. That should have showed up in slower healthcare cost growth already. Now, admittedly, parsing whether it has would require a more sophisticated analysis than I'm presenting here, but I think it's worth pointing out that real age-adjusted per capita healthcare spending has in most countries continued to rise as fast or faster, and in the United States, much faster than per capita GDP. So clearly there are other forces at work here. There's more than the health of the elderly that's relevant. And that's everything from the introduction of new medical technologies to growing public expectations about care and cure and what the healthcare system will deliver. Good health, moreover, is not a fixed goal. It's a subjective standard that rises over time as societies become more affluent, more risk averse, and more secular. That is, more apt to see the ultimate goal of life as happiness in the here and now. So you put these other forces together, and what you get is a transformation of medical practice. Where healthcare once meant an occasional visit to the doctor or the hospital, it's now fast becoming a process of lifelong fine-tuning and intervention in which no extra dollar or euro or yen spent might not have, at least at the margin, some potential incremental benefit. Next slide. So let me sum up. I think it's fair to say, excuse me just a second. I think it's fair to say that there's room for optimism on the ability of aging societies to extend work lives. Even if disability rates don't decline further in the future, the current health profile, overall health profile in terms of functional health and limitations on ability to work is broadly similar in the 60s and early 70s to what it is in the 50s. So there's room for improvement. However, there's also ample cause for concern, especially in the United States. As I've already mentioned, the worsening health profile of younger and midlife adults could not just prevent further declines in elderly disability in the future, but could actually lead to a reversal of the progress that's been made. And then there's the huge and growing divergence in US life expectancy and health expectancy by income and educational attainment. The chart here shows cohort life expectancy at age 50 for the 1930 cohort versus the 1960 cohort. You can see for both men and women, very large gains in life expectancy in the fifth quintile, and essentially no gain in the first quintile, even a slight decline. This is likely to add yet one more force increasing inequality to those that we're already dealing with. Next slide. When it comes to acute care spending, I'm much less optimistic. If you take a look at the chart, or the table rather, on the right, I've tabulated, and these are, I believe, borrowed from the OECD, the ratio of acute care spending on the elderly to non-elderly, 60 and over. The numbers on the chart are too small for me to read, but I think 60 to 84 and 85 and over. And as you can see, the ratios, especially for the younger elderly age bracket, are remarkably similar across countries. And this is despite very significant differences in disability rates and healthy life expectancy across these same countries. My take, and clearly there's room for debate here, but my take is that controlling the rate of growth in acute care spending is going to require broader health system reform. That's a topic for another day, but it would involve imposing some sort of budget constraint on the healthcare system, which most developed countries have done, but the United States has not. Next slide. Finally, just a few words about long-term care spending. Here, falling rates of disability should obviously lead to falling demand for long-term care services. Or I should say, slower growth in demand for long-term care services, because the oldest elderly age brackets are growing so rapidly that even if disability rates are falling at those ages, you're likely to still have an increase in aggregate demand. But slower growth in that demand due to falling disability seems like a good bet. The open question is, will that lead to lower burdens on families and government? And the point to keep in mind here is that disability isn't the only thing that determines the demand for long-term care, particularly formal paid long-term care services. Long-term care is the demand for it is highly dependent on a host of other socio-demographic factors, and particularly the strength of extended families. Tomorrow's elderly will be much more likely than today's elderly to have never been married, to have been divorced, to have had no children, to have had one child, to live far from their children, and so forth. So it is entirely possible that even if the growth in demand for long-term care falls, that the burden on individual caregivers will rise. And in some European countries, the Nordic countries in particular, that have almost entirely socialized the cost of long-term care, this may not lead to extra costs showing up in public budgets, but for countries like the United States or Italy, where the extended family plays still a very large, even a dominant role, it will lead to increasing cost pressure to shift these costs to public budgets. So let me stop there. I've probably raised more questions than I've answered, but maybe that's one of the purposes of a conference like this. At least I hope it is, and I hope I've set up the following speakers who will more directly address, I believe, the impact of the pandemic on aging and health. Thank you.
Thank you so much, Richard. Just absolutely spectacular presentation, and it does bring up, at least it inspires you to think about these issues a lot more. I did have just a couple of quick comments before we get to the next speakers. The first one is, thank you for asking me to advance the slides, but I just want to make it clear I was not the one advancing the slides. So Nadej, back in the control room, thank you very much for advancing the slides. I will say that we were up to, I guess you see it too, but we were up to a high of about 127 participants at one point, and they remained steady the whole time, Richard. So everybody was listening very carefully. We'll see if David and Andrew can continue with that, or if everybody drops off when they start speaking. So good job. That was great, Richard. You talked about the good, the bad, and the ugly. I won't ask which one I am, but it is one of my favorite movies, I have to say. On a more serious note, one of the things about aging that we'll probably talk about later, maybe a little bit in the discussion, Richard, is you talked about the disparity between that's getting worse between poorer people and more wealthy people. But that happens also as age increases and we want to work longer. People in blue collar jobs just can't physically do it anymore. So I think that even broadens it more, and maybe we'll talk a little bit about that. And then also, you and I had this discussion that time where we were talking for 45 minutes one evening, my time, and we talked about that as people are living longer, and if you believe in that life expectancies will increase, or you're squaring the or rectangular, part of the curve, we're not sure that the human body, that the brain is built to last that long too. So you might see more dementia and things like that. So now, without any further ado, I think I'll reintroduce David and Andrew. David, the show is all yours. Okay, how come we don't hear them? Oh.
David, still muted.
Okay, can you hear me now?
Yes.
Okay, so thank you very much, Ronnie and Richard, Yanela and Jad. Richard was talking about the world pre-COVID and the possible trends pre-COVID. We're going to talk about the impact of COVID on higher age mortality. This is joint work with Amy Kessler and Marsha Kessler. So next slide, please, Andrew. And the motivation was when the outbreak started in March, Amy approached us and said, you know, let's look at what's happening here. We're all interested in higher age mortality developments, in pensions and in the pension risk transfer market. And we'd heard that the effect was on higher ages in particular. And so we started to look at data initially, and then we kind of came up with some models. So the kind of two issues that we were looking at way back in March were the demographic profile of the COVID-19 victims. That was the first thing. And in particular, the relationship between COVID mortality and all-cause mortality. And by all-cause mortality, we're going to look at what was happening to mortality from all causes pre-pandemic, either the year before the pandemic or say the average of the previous 5 years, and looking at whether there was a relationship or what was the relationship between COVID mortality and all-cause mortality in the world that Richard was describing. And then the next thing, of course, is what are the infection rates? What do we know about infection rates in different groups? And so those are the two things that would have influenced the mortality of the victims. And then the second thing was to look at the demographic profile of the surviving population. And our initial data analysis seemed to suggest that a lot of people, or some people who would have died in the near term anyway, they died as a result of COVID, and their deaths were brought forward by COVID. And that led us to develop what we've called the accelerated deaths model. And of course, we want to know about the life expectancy of the survivors and whether that has increased or not, whether the survivors are actually much healthier and their life expectancy is much healthier than those who died sooner than they otherwise would. So we call this Adam's apple, the accelerated deaths model and the adjusted post-pandemic life expectancy. But there are also secondary effects, and we're still learning about these. We've heard about long COVID in recent weeks, about the fact that even very young people who've survived COVID, they are saying that they are much weaker, that their energy is half of what it was before they had caught the disease. There's the excess cancers and the other excess deaths that will have occurred because of effectively the world's hospital systems closed down and they became the COVID system. We have a National Health Service in the UK, and it became the National COVID Service, and all the other illnesses, cancer in particular, the treatment was delayed, the diagnosis was delayed, and that will lead to a number of excess deaths. Then there's the issue of the consequences of unemployment and isolation, and whether there will be deaths of despair as a result of that. And this finally, Andrew will go on about this in more detail, whether the kind of scientific developments, the vaccines, and whether the demand for anti-aging treatments, what effect they will have. Now we're going to focus on data for England. Has a high quality data set that we have access to, but we believe that the model that Andrew will develop has applications to other countries. But what we want to make clear, what we're not doing is we're not predicting the size of the pandemic or even the number of waves of the pandemic. That's not our job. We're not epidemiologists. But what our model, we think, can do is that given the total number of deaths, our model can estimate the breakdown between the different demographic groups. So we do think our model has very useful features to it going forward. So just the next slide, please. So we've seen some headlines, and Yanela mentioned some of them, and I'm going to just go over some of the other ones that we've seen here. The BBC News, coronavirus death rates are twice as high in deprived areas. In another interview, the UK president of the Academy of Medical Sciences says that COVID exaggerates inequality in whichever direction you turn. The National Health Service Confederation, which represents the providers in different regions of the country, the Office for National Statistic Data lays bare ravages of COVID-19 in areas of high deprivation. Then Health Europa, the disproportionate impact of COVID-19 on senior populations. And there are thousands of these headlines that we will all have seen over the last 6 months. And what we want to try and do here is try and get behind these headlines and look at the evidence and whether these headlines are actually distorting the real picture, and that there are more fundamental causes of the mortality rates at different ages, and particular high ages, so that we've taken a kind of science-led approach to this. So I'm now going to hand over to Andrew to kind of develop this model.
Okay, well, thank you very much, David. So I'll just list here what we see as the objectives of the work that we've been trying to do. So more generally, what we're thinking about is what does the mixture of people who are dying from COVID look like? So what's the age profile of those who die? Do we see more people dying in deprived areas? How does it vary from one region to the next, and so on? And then we can focus on the slightly more scientific issues. So when we look at inequality, if we're looking at mortality inequality amongst the COVID-19 victims, how does that compare with the mortality inequality if you're just looking at the all-cause mortality that you might see in a typical year like 2020? And then the third point is if we look ahead and think about the survivors. So these are people that might have been infected, but it's also people who didn't get infected. But those that we're looking at the survivors of the pandemic. As David mentioned, are these pandemic survivors a bit more healthy than the pre-COVID average? And in particular, will they have higher life expectancies? And then are there implications for pension providers and so on? And then lastly, what we'll touch upon is what are going to be the longer term impacts of this pandemic in terms of the impairments or other things that people might have. Now, this chart was one of the early starting points in terms of our work on analysing the pandemic, and it came out of a blog written by David Spiegelhalter, a well-known statistician in the United Kingdom. And it's comparing COVID-19 mortality with all-cause mortality. So for both females and for males, we've got the dots, which are the annualized mortality rates for March to June for COVID. So that's the dots. And then I'm comparing that with the all-cause mortality that we can observe for the same national populations. And we've got, we're plotting these both on a logarithmic scale, and part of that is just to help us to compare young and old in the same sort of graphic. But also when you plot it on a logarithmic scale, you get this relatively linear shape. Now, when we look at all-cause mortality, I've also put here two versions of the all-cause curve. So the dashed curve is the true all-cause mortality. But because we're here thinking about underlying health, the solid line is all cause, but it is excluding external causes of death. So things like accidents and suicides, and so that's leaving us with the underlying health of the population rather than these accidental deaths. Now, the very striking thing about both of these graphics, males and females, is the fact that, well, the lines are almost all linear, approximately, but also that the COVID curves are almost parallel to the all-cause mortality curves. And that was really a very striking observation. And it was really suggesting to us at the early stages in our work that COVID death rates by age are approximately proportional to all-cause mortality, excluding external causes. So what do we take away from this? Well, what it does is it suggests a way for us to break down what we're interested in. So we're interested in the COVID mortality, but we can break this down into 3 factors. So first of all, we have the all-cause mortality rate. We then have to think about the infection rate, which is slightly harder to pin down. And then the third component is something that we call relative frailty. Now, this equation, it's a matter of fact, but it's the relative frailty that is really the balancing item. And what it does is it measures the probability of death from COVID-19 if you are infected relative to the annual probability of death from all causes. Now, thinking about these graphics that we've just looked at, the graphic suggests that the infection rate multiplied by the relative frailty together, that these do not depend much on age, a little bit, and then there's also a little bit of dependence on gender. So that's one of the takeaways, but obviously what we want to do is to analyze this in more detail when we start to get the right sorts of data to be able to look at this in more detail. And then there's a further pairing, which is if we look at the infection rate multiplied by the relative frailty, all-cause mortality multiplied by relative frailty, then this is what is often referred to as the infection fatality rate. It's the probability of dying from COVID-19 if you have been infected. Now, the infection fatality rate is a much discussed quantity and often not that well understood by the general population. Now, in England, what we know is that on average is about 6% of the population in the first wave were infected by COVID-19. We know that from a large-scale antibody study. Now, what I'm doing in this graphic here is a very simplistic approach to scaling up what we have observed. So if we were to assume that across all ages and all subgroups that it was 6%, we could scale that up. We could say, well, what would happen if everybody was infected? And so the black curve is the actual mortality that we observed. And then here, the red curve up at the top is the scaled up. So if there was 100% infection rates, what would the mortality rates look like? And what we can see here is that the infection fatality rate is around about 1 at the younger ages to 2 times the annual all-cause death rate. Just remember that it's on a logarithmic scale. So the 1 times or 2 times, that's what we take from that graphic. So that's saying that with 2 times, that if you get infected, then the chances of dying, whatever that is, that's likely to be double your chances of dying from any other cause during the next year. Now, of course, this is just the starting point for a more detailed analysis, but it gives us an initial feel for what the infection fatality rate looks like. Now, we can then start to generalize this concept. So we know that all individuals of the same age are not all the same in terms of their health or frailty or mortality prospects. Some are much more likely to die in the next year than others. And we can certainly see this at the subgroup level. So if we were, say, looking at deprivation, so the most deprived groups in society have typically much higher death rates than the least deprived groups within society. And this is the result of, on average, poorer states of health in the more deprived groups. And that, of course, is itself the result of individual risk factors. So things like higher levels of smoking, poorer diets, less exercise, things of that sort. So we can see these differences in all-cause mortality and frailty in different groups. And that's just a reminder that people of the same age have all varying levels of health. Now, for COVID-19, what we've also observed is that people who have underlying conditions tend to be much more likely to die from COVID-19. And if we put this slightly more scientifically, first of all, older people are more at risk, simply because they have more comorbidities than younger people in the population. But then also within a particular age cohort or age group, people who have more comorbidities than the average for that age group are more at risk. So that just allows us to generalize this equation that we had a couple of slides back. So instead of the COVID mortality rate simply being age dependent, I've now introduced this I into the equation. So we now have by COVID mortality by group and also by age. And the group itself might be deprivation related, or it could be regional variation, or it might be by ethnic group, or it could be some combination of these. So we might have many groups that we can look at. And our key hypothesis in the work that part of the work that we've been doing is that the relative frailty that we have in this equation here, that does not vary much, not just by age, but it doesn't vary much by subgroup either. In other words, differences that we do see in COVID mortality rates between groups is largely due to differences in all-cause mortality and also in different infection rates between different groups. So if we then think about the individual level, we can extend things just a little bit further because we're saying that it doesn't vary much by age or subgroup, but we could even think about extending that down to the level of the individual. But if we do that, we might need to modify the AIR equation. So rather than using all-cause mortality, we might focus on selected causes. And these selected causes might reflect those comorbidities that are believed to be linked to higher COVID-19 risk. So I'll move on now to look at infection rates. So early as evidence that we had right in the April and May was that we had quite significant regional variation, and London in particular had experienced much higher infection rates compared to other parts of the country. And then we also had the results of antigen testing, so people that were currently infected that could be found to be positive or negative. And then more recently, Imperial College has published the results of a large randomized survey with about 100,000 people. And the sort of headline was that they found, and I mentioned this before, that around about 6% on average were carrying antibodies. But there was a lot of variation through the population in terms of what the percentages are. And in the paper that they published, it's measured through odds ratios, and the multipliers here are, say, 1.4 times. That would mean that for this particular group, that their infection rates were 40% higher than the reference group, age 35 to 44. Now, looking at other groupings, first of all, males and females, well, what they found was very similar infection rates. Perhaps slightly more surprisingly, when we look at deprivation quintiles, what they found was really very similar infection rates across all 5 quintiles, with 1.1 times, so slightly higher infection rates in the most deprived groups versus the least deprived as the reference group. Then London, regional variation was found to be very significant. So this is the opposite of what we've seen in terms of small variation. So London had the highest infection rates at around about 2.4 times the reference group. Also very significant variation, and this was mentioned in the Unella's introductory comments, that we see very big differences between blacks and Asians versus the white population. Healthcare workers, maybe not surprising, very high infection rates compared to the rest of the occupational groups. And then again, maybe not a big surprise that if you live in a large household, then you are much more likely to be infected than if you were living on your own. The next thing I'll talk about is looking at age standardized mortality rates. So the age standardized mortality rate, it's a weighted average of the single age death rates, and it's weights based on a standard population. And in this chart here from the Office for National Statistics, the ONS, we're looking at ASMRs by deprivation, with the most deprived group on the right and the least deprived on the left. And what we're looking at here is the blue bars are the COVID mortality, and the grey bars are the all-cause mortality. And the scale that we're looking at is the ASMR relative to group 10. So the 0 is group 10 itself, and then it's excess mortality as a percentage of the group 10. Now, in this chart, it's the same plot, but just a few more comments about what we're seeing here. So what the ONS highlighted was the three most deprived groups. What we see in this chart is that the blue bars are way above the grey bars, the all-cause mortality. So COVID mortality much higher in terms of inequality between group 1 and group 10. And so this led to the headline that the most deprived groups were disproportionately affected. However, we have to be really very careful here, because what we see is that, I've commented on already, is that London had much higher infection rates. But what we also know is that London also has much higher levels of deprivation compared to the national population. And perhaps that is distorting these numbers that we're seeing here. Now, the ONS also, fortunately, were publishing at the same time ASMRs by region. And this additional information allowed us to filter out the impact of region and allow us to focus on the sole impact of deprivation. And that's what this chart shows. So the grey and the blue bars are the same as before, but what we've added in are the gold bars, and the gold bars are the ASMRs with the regional effect filtered out. And what we can see now is that, particularly for groups 1, 2, and 3, the gold bars are well below the blue bars, so that London effect was definitely distorting things. But also now that the gold bars are roughly in line with the grey bars. And so that's really saying that across all deciles, that there's not really much difference in terms of the mortality inequality between all-cause mortality on the one hand and COVID-19 mortality on the other. So let's just pull some of these observations together. So here's our equation that we've been looking at. Now, what we've seen a few slides back with the antibody data was that different deprivation groups have very similar infection rates. And then from looking at the ASMRs, what we've seen is that the COVID mortality by deprivation is approximately proportional to all-cause mortality by deprivation. And what do we infer from that? That relative frailty is fairly constant across deprivation groups. And this was in line with our earlier hypothesis that within this equation up at the top, that the relative frailty is reasonably constant, and that any differences that we see in the COVID mortality is down to all-cause and the infection rate. Now, just to sort of add one or two more things into the pot, this is another chart from the ONS, and it's looking at death counts in the month of May 2020 and comparing that with the 5-year average. And of course, up at the top, there's a big blue bar for COVID-19, where there was nothing in the previous 5 years. And then we've got all of the other leading causes of death that go below that. And what I've highlighted here are 4 of the leading causes of death, where the blue bar is actually somewhat short of the 5-year average. And this is perhaps an indication that some people who are dying from COVID-19 are people that would have died from other causes later this year. So, for example, heart disease. So these would be people who are very ill. They die from COVID-19, but they would have died in a month or two's time from something else. Now that, plus some of the preceding discussion, that led us to develop the accelerated deaths model that David mentioned. So an accelerated death is simply someone who would have died in the future, maybe a few months, but maybe years, many years into the future, from other causes. And what we're focusing on in our modeling work is for a given total number of deaths from the pandemic, we're wanting to look at the surviving population. And what we're not trying to do, other people are doing this, what we're not doing is trying to predict the size of the second wave or the third wave. Now, before I actually get to the pandemic itself, I'll start with the actuarial curve of deaths. So for example, if you take a cohort currently aged at 75, the curve of deaths is just basically saying at what age will this group die at. So there'll be some are going to die in their late 70s, but then there will be a peak in the numbers of deaths from this cohort in the late 80s. And then the curve will gradually die down as the cohort itself gradually dies off. Now, a key point about this curve is that the point I mentioned earlier was that amongst this cohort, some individuals are very unhealthy, whereas other individuals within the same cohort are in very good health. And in terms of this death curve, the less healthy people are more likely to feature on the left-hand side of the graphic, and then the more healthy people are more likely to feature in terms of much later deaths. Now let's add in the COVID-19. And this is an exaggerated scenario where we say, well, suppose that 5% of this cohort unfortunately die from COVID. And here the gray slice, or the gray area in the left and the right-hand plots, is that 5%. And it's showing who out of the whole cohort, in terms of their future date of death, who is actually getting picked off by COVID rather than living for 1, 2, 3, or many more years. So on the left, the gray zone is highlighting an example where the 5% are being chosen completely at random from this cohort without reference to their state of health. Whereas on the right, the 5% are more heavily biased towards the less healthy people in the population. And it's this chart on the right-hand side that is much more consistent with the empirical evidence that we've seen in the COVID data, that those with comorbidities are more likely to die if they get infected. Now, we're then thinking about whether the survivors are healthier on average. And of course, the model itself is then allowing us to, first of all, model that gray area, but then to do some calculations. So we can calculate life expectancies before and after the pandemic. And in this very simple example, you can see that there are some differences, but again, this is in an exaggerated scenario. Now, the model, it has 2 parameters. One of them is called amplitude, and the amplitude is a parameter which dictates what proportion of the cohort will die from COVID. And then the second parameter, which is illustrated in the graphics, the second parameter is called the reach, and this is related to the expected years of life lost per person who dies early from COVID-19. And the reach has a big impact on the shape of the grey region. So if you make it more years of life lost, then it is stretching out, it is reaching the healthier end of the spectrum in terms of the current states of health. So here's just 3 scenarios to illustrate the impact on life expectancy. So in this chart, we've got a variety of different current ages. And then what I'm showing on the y-axis is the percentage increase in the life expectancy. So we're comparing the pre-pandemic life expectancy with the adjusted post-pandemic life expectancy, or APPLE. And the three scenarios are, first of all, the sort of central one is where we have 80,000 deaths, which is, and this is for England. So that's slightly more than we've observed so far. The second scenario has 50% higher deaths, and the third scenario has a longer reach, but 80,000 deaths. Now, in all three cases, we see that the impact on life expectancy of the survivors, the APPLE, the increase is really very small. At age 65, it's around about only a 0.2% increase in life expectancy. Slightly higher at higher ages, but still relatively small. But I also want to stress on this slide that this impact assumes no secondary effects, so no long-term impairments. And these are things that need much more data than we have at the moment and further modelling. But that's the point that I'll just pick up on now. So what are the other effects beyond this model? What are these secondary effects? So David mentioned some of these in his introduction. One of them is non-COVID illnesses. So what we know about is that, in particular, things like cancer diagnosis, that people are not getting cancer diagnosis as early as they would normally be getting, and that may well lead to higher mortality. And then there are other diseases or illnesses that people might have that might be delayed. There may be some long-term health impairments, and we're now just starting to see what the magnitude of that is, but we still need to get more data on that. There may be a lasting impact, so this is more on the positive side. There may be lots of innovation that happens during the pandemic that will have lasting benefits beyond COVID-19. Pluses and minuses in terms of behavioural changes. Some people get more exercise, some are sitting at home. And then also mental health issues, which were also highlighted in the introductory speech. We then have to think about things like long-term unemployment if there's resulting from the economic recession. And then we have to also think about what the economic impact of on future health spending might be, and the research. And so that will have an impact on mortality improvement rates in the future. Now, some of these are things that we might be able to observe in 2021 and maybe 2022. So, for example, we might see higher cancer death rates because of these later diagnoses. And then on the other side, we may see lower death rates from other causes of death. So particularly, I'm thinking of respiratory diseases, and this is really due to accelerated death from COVID-19 during 2020. So that the more frail people are dying from COVID-19, and it's a healthier population that remains in 2021. So just to round up now, so going back to the first part of the talk, the data are consistent with observations that people with comorbidities are more likely to die if they get infected with COVID-19. And we've then seen a strong relationship between COVID death rates and all-cause mortality. So by age, by deprivation, potentially other groups. And now here's the key point, that if you have somebody that's infected, then key subgroups are not disproportionately affected by COVID-19 relative to all-cause mortality. So what's really happening is that what COVID has done is to highlight existing inequalities. So I get points that were mentioned in the introductory speech. So it's highlighting these inequalities, but we're not actually seeing even bigger inequalities. And that's maybe what these headlines that David mentioned at the beginning were leading you to conclude. But if we do see differences in COVID mortality rates, then it's much more like that will be the result of these different infection rates in these different populations. And then lastly, for the accelerated deaths model, pandemic survivors will be healthier on average, but with the current scale of deaths as they are, And also in the absence of secondary effects, which are important, the impact on the collective life expectancy of the survivors will be quite small. That's what we think. But secondary effects, they could have a significant additional impact, probably negative, on life expectancies. But it's going to take us several years, perhaps, to be able to properly assess what these impacts are. So that concludes my remarks. I'm not sure, I'll hand back to David just in case you want to add anything to that.
Yes, just to reinforce what you said, we wanted to have a calm assessment about what was happening, and we didn't really like some of these headlines, and we wanted to get behind them and just look at the data and to see what the data was leading us to, and then to build a model. We were the first to come up with this idea of the accelerated deaths. And we would like to see whether the data, our model generalizes to other countries. We've concentrated on England, but we would like to see whether the model works on other countries as well. And as Andrew concluded, all these other longer term things, we could build them in to our model, these longer term impacts, once we've got a better feel for what the data is telling us. We could then expand the model and make it even more general. But we've got a very simple model, and we believe it's going to be a very powerful model because of its simplicity. Thank you.
Okay, back to Ronnie.
Thank you very much, Richard, David, Andrew, great presentation. So just quickly on housekeeping, we will take a 5-minute break, not a 10-minute break, so don't go far away once we end. We'll ask a couple of questions, but we'll try to get back on time here. So first, we did get a question from the audience. Andrew and David, if you go back to slide 5, you could just look at it on your own slide. I don't think you need to put it up here. But if you go back to slide 5, I think it was on the male side, you see the dots, the COVID deaths, and it looks like up to age 50, it looks a little steeper, hitting toward the line. If it continued at the pace, it would hit the all-cause mortality line at some point. But then at the older ages, it flattened out again. So someone asked, it was Jason who asked, could you explain that? It looks visually that way. Is there an explanation for that?
That's a very, very good question. I don't think I really have a good answer for that, because I think this is where we need to just take our time to really get down to the nuts and bolts of the more detailed data that people are starting to gather this data, and really what we're needing to understand exactly that sort of question, or to get an answer for it. We really need to look at the detailed comorbidities, for example, of the people that were dying from COVID-19. And for example, if you were looking at the infection fatality rate, which I said was between 1 time and 2 times the all-cause mortality. So that 1 time was at the lower ages. So that's exactly the point that was being made, that it seems a bit steeper at the younger ages and then slightly flatter at the higher ages. So I think that may be down to the fact that it's particular comorbidities rather than general frailty that matters there. And it may be that certain comorbidities are more prevalent relative to other comorbidities at other ages. So partial answer, but certainly I'm not able at the current time to give up an accurate answer to that.
Next question from the audience, which I think is another good one, is you mentioned, and this was also in Janella's presentation, Richard, it was in your presentation, so anyone can answer this, but I think it's for you, Andrew, because it specifically came up in your presentation. So you mentioned that certain groups are more likely to catch the COVID-19 than other groups, for example, minorities, Blacks in particular. Do you think that there's a specific reason for this? Is it something genetic, like certain genetic diseases? We did hear things about certain blood types more prone to the disease than others. Is it something genetic, or is it a function of healthcare or living conditions or things like that, or a combination?
That's a great question. Again, there are sort of partial answers that I can give rather than anything definitive, but for the UK data, for example, the Blacks and Asians were maybe twice as likely to be infected compared to other groups. And so, I've been thinking about, well, what the potential reasons for that might be. And of course, one explanation which you touched on, Ronnie, was that if you are exposed to the virus, do you become infected? And so there could be perhaps some genetic reasons why, if you are exposed to the virus, that you are more likely to become infected. So that's one possibility. And then there are other reasons which are perhaps more to do, possibly more country specific, but also due to perhaps cultural differences in terms of the way people mix with each other, family groups, things of that sort, which may mean that it's more likely that you get infected just because of the way that people typically like to live their lives. And then, of course, another possible reason is that particular ethnic groups are more likely to have particular types of occupations. So those are sort of possible explanations where I don't really at the moment have the right sorts of data to be able to pin down, well, which one of those or what sort of combination would give those answers in the data. And then added to that, it very much depends on the healthcare system. Very different in the United Kingdom versus the United States. Quite a lot of variation in terms of your access to healthcare. So if you are infected, then there are maybe compounding effects that you might see in the US compared to the UK, where the universal healthcare should ensure that anybody infected and needing hospitalization, that they all get roughly the same level of care.
All right, thank you very much. And Richard, just one last question for you, and then we'll end it so that we'll try to stay as close to on time. I did mention at the end of your presentation about the blue collar workers compared to white collar workers. Do you think that there'll be more disparity in, the aging, the disabilities and healthy aging as time goes on because of this? Because certain occupations cannot continue, or is there a way around that?
Well, my gosh, I feel a lot of responsibility here answering a difficult question like that in final position. I think the short answer is that unless we see a significant improvement in underlying inequality, that we're likely to see a continuation in these substantial and growing differences in life expectancy and health expectancy over time. And this suggests that we need to make broad investments in not just the health of the elderly, or even primarily the health of the elderly, but the health of the future elderly. And I would define health investments very broadly here to include things we often think of as part of social policy rather than healthcare policy. But to my mind, of all of the charts I showed, all of the trends I tried to illustrate, that is indeed the most worrisome.
David, Andrew,
if you're looking for
again, thank you so much for this great presentation. We will go to a 5-minute break, and I will tell you, Andrew, I'm getting a bunch of comments that congratulate you on your backgrounds and your presentation, but mostly your background. So everybody wants to visit your background, and I'm not sure that that's possible. I'm sure it's somewhere, but it's certainly not where you are. Our next, please stay around for the 5 minutes. Our next presentation is absolutely fantastic. And you should stay around because the two gentlemen who are speaking in the next presentation are from the West Coast of the US. So it's quite early in the morning. So they woke up early for us. Let's give them our attention. Welcome back to the Geneva Association Health and Aging Conference 2020. I'm sure you were all, if you were on for the earlier sessions, it's just been fabulous so far. I think it's even going to get better with the next presentation. Again, we have our West Coasters on. So first we have, we'll be speaking first is Steve Vernon. He's a consulting research scholar for financial security and division at Stanford. And I've kidded with Steve already that my son got rejected from Stanford, so I'm really angry with him. But Steve, I don't think that you're on the admissions commission, so I'll give you a break on that one. And then after Steve does his about 30-minute presentation, Dustin Yoder will come up. He's the CEO of Surify. If you haven't heard of it, go look it up. It's a fantastic tech company. I will tell you that both Steve and Dustin are going to share their screens. So please bear with us for that second that it takes for them to grab the screen so they have control of it. They didn't trust us here at the Geneva Association. Those California people just really don't trust anybody. And I will tell you that Dustin is really a technology person. Although he does have insurance in his DNA, I think, is that right? But you'll talk about that. I don't want to talk too much about that. So beware of the tech people. There's something that always gets messed up when they try to share their screens. So first, without any further ado, so we stay on time, Steve, please take it away. We're looking forward to your presentation on drivers of better aging, connecting our physical, mental, and financial lives. Thank you.
Thank you, Ronnie, and thanks for spending time with me today. I'm delighted to share results of surveys and research that we've conducted at the Stanford Center on Longevity. Now, I'm sure you're all aware of the significant improvements in lifespans that we've achieved over the last 100 years. And these increases in lifespan are due to advances that really accrued broadly across the population. So clean water, efficient waste disposal, widespread use of vaccines against infectious diseases, abundant food, refrigeration, improvements in communications and transportation. And so we saw a broad advance, broadly across the population in life expectancy. But evidence is accumulating that if we look for future improvements, continued improvements in lifespans, they're going to accrue to the people who are able to navigate an increasingly complex environment. And they're not going to necessarily accrue broadly across the population. Okay, let's see. My slide's not advancing. Hold on a second here. Okay, here we go. Sorry for the delay. So we're seeing research that's showing that there's an increasingly difference in life expectancy due to things like income, wealth, ethnicity, educational attainment. And what we're seeing is that with this increasingly complex environment, the current environment has elements that are both supportive of improved life expectancy and actually supportive of decreasing life expectancy. And so more than ever, it's those who are either have the knowledge or the capabilities or the ability to navigate this environment that are going to continue to improve their life expectancies. And so at the Stanford Center on Longevity, we got really interested in digging into what are the factors and decisions that people can make that would enable them to live long, healthy lives. So 5 years ago, we started the Sightlines project, and we really wanted to see what were the factors that would influence a person's lifespan and their health span. And we looked at the research and we identified over 100 different possible factors that would improve morbidity and improve health, improve longevity. The data here is US centric, but many of the factors we believe apply around the world. And so really we want to stimulate research and more conversations about how can we be proactive in helping a broad part of the population live long and live well into the 21st century. So we ended up identifying 26 indicators in 3 different domains. And so we looked at indicators of healthy living, financial security, and social engagement. If you look at this black bar, we also identified them by 6 different age groups. And this reflects our philosophy at the Stanford Center on Longevity, is that if you're going to arrive at old age, healthy, financially secure, and socially engaged, you just can't start thinking about that in your 50s and 60s. And really, the way you arrive at old age reflects how you lived your life all throughout your life. And so if we want to improve people's health and longevity, we really need to start looking at people who were born and follow them throughout their lives. So what we wanted to do is look at how are, in this case, Americans doing with respect to these indicators in each of the age groups that we're talking about today. And this can help measure what a prior presenter talked about, is that if you want to look at the health of a 70-year-old in 20 years, you look at the health of a 50-year-old right now. And this kind of data would actually help us track that. Here in just picture form are the actions that we've linked to living a long, healthy life. Healthy living, it's exercise, it's nutrition, low sedentary behavior, eating enough fruits and vegetables, getting sufficient sleep, avoiding risky behaviors. Financial security, it's having manageable debt, emergency funds, threshold income, and this is important, is that we found that people who are living in poverty or even near poverty have higher death rates and higher rates of illness than people who have more wealth than that. And we're trying to dig down, well, what is it about poverty that causes people in those groups to have higher rates of illness and mortality? We looked at what are the participation in savings plans, home ownership, investments, and then finally, what's the coverage due to health insurance, long-term disability care, and life insurance. Now, I have to say in the United States, health insurance is an issue. With most other countries, it's not. And so that is an example of something that's very US-centric, sad to say. We also looked at social engagement and the interactions of meaningful relationships with family, with friends, with spouses, and group involvement, whether you're working, volunteering, participating in community religious activities. These are all the types of activities that the research is linking to living a long, healthy life. So how are Americans doing today? And again, this is US-centric. And what we found, this is just showing by age group, what are the proportions of each age group that are getting it right by the measures that we talked about. And so we're seeing on healthy living, financial security, more than half of the folks are getting it right by our measures, but there's a lot of room for improvement. Social engagement is really tougher to measure, but less folks are getting it right in that sense. And what really is challenging here is trying to assess the efficacy of new ways of remaining socially engaged. So is talking with someone on Zoom, does that give you as much benefits as actually being in the room with them? And that's something that research really hasn't figured out yet. We also measured how we are doing, in this case, it was in 2016 versus 10 to 15 years prior, to see, are we improving or are things backsliding? And what we could see on healthy living, there are some gains going on, but they're offset by some risks. So people not getting enough exercise, not eating as well, more obesity. These are all things that are offsetting other gains like reduced smoking and healthy living. With financial security, things were definitely worse compared to 10 or 15 years ago. And this is attributed largely to the Great Recession and the economic outputs from that. And finally, social engagement. We found that traditional social engagements are waning. And what's really unknown is, are we offsetting that with things like Facebook and Zoom? Let's dig down, because we also looked at different cuts in the data. And you can see in the boxes here, we looked at ethnicity, income, education, and marital status to see how different groups are faring. I'm going to focus here on ethnicity. And what we saw was that if you look in this graph, the dots are showing the percent of Americans living in poverty or near poverty. And the dark dots are in 2016, and the circles, the open circles, are 10 to 15 years prior. So you can measure either the backsliding or the improvement. And what we're seeing here is that Blacks and Hispanics are more likely to live in poverty or near poverty than whites and Asians. We looked at home ownership, and once again, by ethnicity, we're seeing that whites are more likely to own their home compared to Blacks, Hispanics, and Asians. Less likely to have health insurance. And this is also very US centric, but African Americans and Hispanics are less likely to have health insurance across the ages. But I do want to draw your attention to the older age groups, 65 and over. Then it's fairly even. And that is the effect of Medicare, which is in the United States, the only universal healthcare system that we have. And so to me, this is actually showing the importance of having a universal healthcare system. All you folks in the other countries, you can just say, yep, we knew that. African Americans and Hispanics are less likely to participate in retirement plans. And when you look at the actual contribution for those people who are participating in retirement plans, whites are contributing at higher rates than Blacks and Hispanics. And so really there's just an overwhelming amount of evidence that in various ways that all add up to your health and longevity. There's not one silver bullet here, but there are a number of different factors that are all adding up to how long you live, how long you'll be financially secure, and how long you'll be healthy. We took a quick look here. I'm not going to dwell on this because Andrew and David and Richard looked into this in detail, but basically we're saying the pandemic is making all these factors worse. People are less likely to get exercise. They're more socially isolated. They're having financial strains. And so across all these indicators, the pandemic is just making things worse. This graph here just shows all-cause mortality in the US. And what I like about this is that the different countries might have different ways of measuring COVID infection and deaths caused by COVID. But if you just look at all-cause mortality, you're either dead or you're not. And if that rate is going up compared to what you would expect normally, then we can see that COVID is really having a significant impact. I'm not going to dwell on this because this was really covered extensively in the prior presentations. So I want to shift to what I did with this data and some of my colleagues is we said, well, given all this research, what are the decisions that individuals should make to help them live a long, healthy life? And particularly as they transition into retirement, what decisions should we focus on? And I like this because when I hear financial institutions and financial advisors say that they want to be in the longevity business, often they're using that to rationalize selling an annuity. Now, annuities are important longevity tools, but being in the longevity business is much more robust and has many more factors than simply selling an annuity. And so I think those financial institutions who want to be in the longevity business could do well to pay attention to all the decisions that will help people live long, healthy lives. From a financial perspective, as you're transitioning into retirement, the top decisions are when and how to retire. And by how to retire, I mean, are you going to work part-time for a while, or are you just going to stop working and never work for income again? When to start Social Security, and for other countries, that's Pillar 1 benefits. Building your retirement income portfolio with invested assets and pensions and annuities. And this is the only step that involves investing. And too often people confuse retirement planning with investments. And they just say, tell me the right investment to have. Well, investing is important also, but it's only one step out of all these steps here. Making smart choices for medical insurance and Medicare, and this is very US centric, but there are traps for the unwary, even in retirement. Even with the universal system that we have with Medicare, there are still traps there that can get people and cause them to spend way more money than they thought they would. And finally, which living expenses to reduce? Because I've seen evidence, which I'll show in a little bit, that the vast majority of older workers in the US approaching retirement age have not saved enough money to retire full-time at age 65 under their current standard of living. And so they're either going to need to work longer if they can, or reduce their spending, or some combination. Now, I think that most people, when they're faced with tough challenges, they value truth and authenticity. And that's where financial institutions can help people assess their situation. Stop showing pictures of happy couples walking on the beach. Instead, let's show the reality of their situation to help them make these tough decisions. That was just the top 5 decisions. Let's keep going. Number 6 is whether to deploy your home equity. Because at least in the United States, we're seeing evidence that large parts of the population, 3/4, have more wealth in their home than they might in their IRA and their 401k. And so how they deploy that home equity might affect their financial security in retirement. Protecting against long-term care expenses, protecting against diminished capacity as you age. And this is a project I'm working on at the Center on Longevity, is developing a toolkit to help people protect themselves in their 80s and 90s when they have diminished capacity to make financial decisions. Watch for that in Q1 of 2021. Providing for your spouse after you're gone. As an actuary, I can predict that if you're married, one of you is going to pass away first and the other one's going to be aging alone. And it's not being morbid, it's just being responsible to plan for that inevitability. And then finally, if you want to leave a legacy, that's after you pass on, that is money that you didn't spend on yourself while you're alive. And so if leaving a legacy is important to you, it's going to reduce the amount of cash flow that you might enjoy while you were alive. And it's just something to plan for. Now, most people don't have the expertise to make these decisions. And so this is where financial institutions and financial advisors can really help by helping people navigate all these decisions, not just selling them an annuity, but you can build trust and maybe sell them an annuity by helping them navigate all these decisions. You got to help people survive stock market crashes, because if you're going to live 25 to 30 years in retirement, how many stock market crashes are in your future? And you need to be able to survive those without knowing when they will happen, because nobody has really accurately predicted stock market crashes. This cartoon here summarizes well that research that I told you about earlier. Help, I haven't saved enough for retirement. And that is the dilemma that most Americans are in right now, is that they're going to have to navigate these tough decisions, whether they should work longer if they can, or reduce their spending. So I want to illustrate what I'm talking about by an example that I've constructed. And I'm saying, meet Rob and Betty. Both are age 62. They live in the US. This is US centric, although it does reflect some other development or the other statuses of retirement adequacy in other countries. Both work and their household income is $100,000 per year. And they've saved $350,000 towards retirement, which happens to be higher than the median that we've seen in the study that I talked about. And they're trying to figure out, can they retire at 62? For them, under Social Security in the US, their full retirement age is 66.5 or age 70. And I'm going to look at some baseline retirement scenarios for Rob and Betty. And one is just retiring immediately at age 62, starting their Social Security and drawing down their assets. The second is working part-time from 62 to 66.5 and then starting Social Security and drawdown. They're only working enough to cover their basic living expenses and they do not continue to save for retirement. Whereas scenario 3 is working full-time from age 62 to 66.5. Then they start Social Security and drawing down their savings. In this scenario, they continue to save towards retirement. And then scenarios 4 and 5 is a downshifting strategy from until age 70. And scenario 5 is working full-time until age 70. So these are just some baseline scenarios. And this graph here now shows what Rob and Betty's retirement income is under these scenarios. And this is what I call age 62 to 70, the retirement opportunity zone. because at age 62, their retirement income is $37,000 and change, whereas at age 70, it's almost double. So the decisions they make between age 62 and 70 will significantly improve or affect their retirement security. I also want to draw your attention to the differences between scenario 2 and 3, because a lot of older people in their 60s express a desire to continue working. Maybe they know they need to keep working, but they just don't want to work at the same pace that they've been working at throughout their lives. And you can see by comparing scenarios 2 and 3 that there is a difference in retirement income. Scenario 3 does generate a little bit more income, but not a lot. And so this kind of analysis can help justify a downshifting strategy. Now, these analyses are beyond the expertise and beyond the skills of most people. And so this is where financial institutions can help, is help their customers piece together their sources of retirement income at different ages. And in the process, you can gain a lot of trust. Our research is showing that the vast majority of middle-income retirees will have a high degree of risk-protected income. And so all I'm doing is showing Social Security, which is protected against inflation risk, longevity risk, and investment risk, compared to the parts that are from invested assets and that are at risk. The percentages here that I'm showing by the bars are just the percent of total income that is risk protected. And we're seeing roughly 3/4 of retirement income is risk protected. And I'll ask you, do they really need more risk protected income? Some people will say yes, and some people will say no, but this is the risk assessment that people need to make. Those are the folks who you can sell annuities, who want more risk protected income. Now let's talk about replacement ratios and what percent of your pay did you replace in these different scenarios. And you hear this conventional wisdom that you need 70 to 80% replacement to have a comfortable retirement. And it just makes me cringe when I hear that, because the vast majority of American workers aren't going to hit that goal. It may be a desirable goal, but they're just not going to hit it. And so only if you worked in some way till age 70 did you get close to that 70% replacement ratio. This illustrates the tough choices that a lot of people are going to need to make, is either work longer or reduce their spending. And I think when people are faced with tough choices, they value someone helping them learn the reality of their situation so that then they can make choices that make sense for them. This really sums up what I've been saying. And this is John Chauvin, who's a professor of economics at Stanford. He said it's very expensive to fund a 30-year retirement over a 40-year career. And think about it. If you enter the workforce at age 22, work for 40 years, you're age 62. And if you're married, it's not unrealistic to expect one of you to maybe live 25 to 30 years. It's just real expensive. So in some way, we need to help people work longer. This isn't going to be easy, but this is the hard work that we need to do. I've been talking about financial decisions, but they're also very important lifestyle decisions. And so I like to say that building your life portfolio is just as important as building your financial portfolio. And I'm not going to dwell on this, other than to say that these are the kinds of things that financial institutions can bring to the attention of their customers to help them make these important decisions, because these decisions will actually impact their financial security. So it's the general location to live, the specific home and community, steps to enhance your health. And these are all coming from the Sightline study that I talked about earlier. Building their healthcare team, developing health metrics, because you can actually track your vulnerability to expensive chronic diseases with metrics that might predict that in advance. Nurture your well-being, developing your social portfolio, which is just as important as your financial portfolio, and working and volunteering in some ways. And for some people, they want to have a non-financial legacy. What are the values you want to pass along to the next generation? And so these are all the decisions that go into being a longevity consultant. I want to switch gears a little bit as to how do you help people make decisions. And as an actuary, it was fairly humbling to realize that people don't always make decisions by the numbers or by the analyses. And a number of psychological factors or behavioral economics factors go into effect. And so we actually read all the papers on behavioral economics and psychology that can influence people's decision making. I don't have time to go into this now, other than just make the point that this is an important point to pay attention to. I'm going to share just one of many of these factors, and this is the impact of stories. And a story is either a narrative that someone has in their head, maybe it's an example of an older friend or relative, it's an urban legend, but it's something that might influence how well they take care of themselves. Here's one that I've heard: none of the men in my family lived past age 75. And they use this to justify short-sighted decisions. But then here's one that I'm seeing more often now. My neighbor's 97-year-old aunt ran out of money and had to move in with her. The aunt didn't think she would live that long. My mother died of cancer at age 54. Enjoy it while you can. You just never know how long you'll live. And so this leads us to the question, what influences health and longevity? Is it your genes or your lifestyle decisions? It's really hard to nail that down precisely, but what the evidence is showing is that your lifestyle decisions are probably more important than your genes, with a few exceptions. And so we can't do much about what our genes are, but we can influence the decisions we make regarding our lifestyle. And by lifestyle decisions, I mean all that life portfolio that I was showing you earlier. And here's a quote that I like from Jack Rowe, who's a prominent researcher and geriatrician. For all but the most strongly determined genetic diseases, the MacArthur studies show that the environment and lifestyle have a powerful impact on the likelihood of actually developing the disorder. This is wonderful news for individuals with strong family histories of some cancers, heart disease, hypertension, rheumatoid arthritis, and many other conditions. We now know that exercise, diet, and even medications may delay or completely eliminate the emergence of the disease. I like this because this gets at those folks who say none of the men in my family lived past age 75. It should give them some hope to make longer decisions. So I want to wrap up with some discussion questions for the audience here. How can you address this longevity inequality? What role do financial institutions have in helping society at large make improvements? How can you help your customers make effective decisions, not just with buying an annuity or buying life insurance or investments, but all the financial decisions? And in the process, you can gain trust and then help sell annuities and life insurance and investments. How can you accommodate longer working lives as an employer yourself, but also how can you facilitate that in the population? Because this is one of the hard work that individuals and employers need to make to help people live and work longer. Because if they're living longer, some of that extra life needs to be spent working longer. And what's the best way to deploy behavioral economics and psychological science? I think that financial institutions and advisors are just at the beginning of understanding how people make decisions. And we really need to focus on how can we go beyond just showing those pictures of the smiling couple walking on the beach. I'm just going to share, if you're interested in this, I could speak for hours on this topic, but if you're interested in more information, I'm just going to show you some of the research reports that support what I just went through. The Sightlines report is one of them, and we did our full report in 2016, and right now we're in the process of updating the report for 2021. We've done in-between studies in 2018 and 2019 on focused topics, but we are updating the full set of metrics in 2021. And so we're looking for financial institutions to collaborate with and provide support in this project, because we think this can really help us dig down even further in the factors that improve health and longevity, with the idea of inequality and COVID in mind. Here are some reports we presented in the past, a collaboration between the Society of Actuaries and the Stanford Center on Longevity. And these are all reports on generating retirement income and retirement security strategies. There's a Sightlines report on the left, the More Design, which is our report that we analyze different academic studies on behavioral economics. And then the report on the right is the one that documents that older working Americans haven't saved enough money for retirement. I've written a couple books on this, Financial Strategies on the left, Robust Strategies on the right, And so I took all this research that we talked about and focused on how can individuals and their advisors make sense of all this research to help their customers. I'd like to end with an inspiring picture. This is a picture I took many years ago, and this is my father on the left running a hurdles race. He's in his late 60s or early 70s, and I thought that this is a good metaphor for people living throughout the rest of their lives. They're going to face challenges, inflation, stock market crashes, maybe their poor health, people pass away. That's just part of the landscape of living into your later years. Imagine a hurdler who said, I would have won if it weren't for the hurdles in the way. And you just kind of laugh at that. My father didn't just show up for the races and run them. He trained and he practiced. And so I think that this is a good metaphor for living out your life throughout retirement. And I think that financial institutions and financial advisors can help their customers win their retirement race. So thanks for spending time with me today, and I look forward to the next presentation. Bye-bye.
Thanks so much, Steve. Absolutely inspiring. I will tell you, this whole idea of the financial and mental and physical health all coming together. For those of you who know me in the audience and the speakers, I'm a huge tennis fan. And I often talk to people and they say that, oh yeah, sometimes toward the end of the matches, they make mental mistakes. And I say, you got to work on your fitness. And it's just funny how your fitness will help your mental, help you limit your mental mistakes. And it's the same thing here. I think that if you plan for the future, if you have a plan, and then if you actually are saving money and feel confident about the future, somehow it helps you with your mental health and your physical health as well. So it all does come together. And I loved your slide on the 70 to 80% rule. Some people say 60%. And sometimes you get this feeling like, well, I can't make 60%, so why even worry about it? And that's not the case. You should work to get the number as large as you can. I think that's great. Well, now we're going to turn over to Dustin, and then we'll have some questions at the end. And Dustin's tech company, Surify, is, they work to modernize the life insurance and annuity industry. And Dustin will tell you a little bit about himself, so you get that, a little bit about the company, and then talk about this connecting of mental health and physical health and financial health. So Dustin, thanks very much. Just before you start with the presentation, tell us when the last time you wore a button-down shirt was. So over to you, Dustin.
Yeah, that's a great question. I don't know about everybody else, but I feel like our our dry cleaning businesses are not doing as well. So yeah, this one was special for all of you here. But it's been a couple of weeks. I find myself on a few webinars these days and try to look presentable. But Ronnie likes to make fun of me and pretend I just wear a T-shirt every day. But that was because you had me on a 5 a.m. the other day, so you saw me at my my best. Well, it's a pleasure to be with everyone today. Ronnie, confirming everyone can see my screen. We are good to go. Let me know. Someone let me know if not. But true pleasure to be here. As mentioned, I stand out as maybe someone that's not qualified to speak at this great conference, largely because I'm not an expert in longevity. But what I focus on is how life insurance and the annuity business is changing, specifically from a tech-enabled way, as well as bringing in kind of new products that tech's enabling. I figure the fact that that's my high level of what I do, but a little background why is a guy like me in this business. I actually grew up. My father was a Guardian career agent. My first baseball team was called Jardine. And I've been actually helping build different insurance technology since I was about 16, when my father was building employee benefits platforms. So I've really, it's funny, people ask how'd you get here. It's like there was a level of comfort that I had with looking at life, annuity, and insurance in general that I feel as though, kind of prepared me for this. Also, I did start building Surify about 8 years ago. I think for all of you, it's interesting maybe to look back at, kind of where people have come from, as well as, kind of where we are today. I initially in 2013 was looking at how to put all your insurance in one place. This was a direct to consumer model in which, if you know mint.com, I was looking to kind of bring your insurance to one place so that so that you could look at it, have an overall risk score, like a credit score, actually. No one woke up in the morning wanting to put their insurance to one place. So I moved on. In 2014, we actually built a life insurance learning platform. Obviously, it's starting to hint at where the world has gone, but ultimately looking at, educating people on life insurance and those decisions early on. If you can believe it, I wrote and reviewed, 24 different types of policies, riders, you name it. And then, you had the epiphany that no one wakes up in the morning wanting to learn about life insurance. It's kind of an interesting thing. I always say, if you're going to write a book, I may read it, but it may not be a New York Times bestseller. And then actually in 15, which is kind of where the direction that we're heading and discussed today, we built a direct to consumer. We were building a new personalized premium policy, like a health connected life insurance. If you've been following, the telematics industry with cars, that's actually what inspired me. This is about the same time you had the John Hancock Vitality, which I'll get into a little bit, but ultimately looking at a premium that would adjust and actually only go down, unlike telematics auto insurance, which goes up because people naturally drive more potentially or drive worse, looking at encouraging people to live longer, healthier, happier lives. The truth is, I changed from all those. I was quite early in that. The insurtech industry hadn't taken off. And since then, I've been focused on enabling life insurance companies to sell insurance, engage with their policyholders, and service their policyholders. These may sound basic, but in actuality, the industry in general, as been highlighted even today, is that we see still the largest portion, 90+% being sold through agents, FAs, advisors, brokers, et cetera. But maybe more importantly, the lack of digital enablement in these areas, as well as post-sale, is huge. This is all going to come together. I think this story is relevant to as we review the life and annuity business here and the changes that we're seeing as these new digital capabilities are creating vast new opportunities to serve the industry and encourage longer, happier, healthier, lives with, physical, mental, and financial well-being. Just so you know, I'm not some crazy individual just selling a story. We have some great clients. We have quite a bit more than this, but these ones I'm allowed to share. And so these are some of the, kind of the North American, clients, looking down this path and looking to evolve their life and annuity businesses in some of the areas that I'll highlight today. But, the truth is, why are we all here? Why did I get invited to present here? And I think the truth of the matter is just since COVID, our daily lives have changed. Let's be honest, Uber, Zoom, and Amazon were here long before COVID, but COVID accelerated and really poured gas on the situation around digital, around how technology is here to change. It has changed the world, but also changed, even the simple things of how my grandmother, who doesn't even use a smartphone, actually just got a new device to communicate with all of us, a tablet, and we're doing it that way due to them being in their 90s. So the world is changing. I'd also say for all of you that are specifically in the U.S., what we're seeing in the U.S. around new life insurance and annuity entrants, with a specific focus, or many of them with a specific focus on technology, gives a lens into what's coming down the pipe. And I will call out that many, we're still in an immature state, and it's really just started to rapidly change. I always like to highlight the fact that, what we're seeing in life and annuity, we're seeing a lot of the same marketing. So I'll get to kind of these rapid changes on health, finance, and financial well-being, but I will tell you that it is still resonating, this whole marketing, like a parent, right? Protect what matters, etc. The truth is, so many of the great products in this space are still there to cover the things that are so important to us, and they've been important for 100 years, right? So the reason we're able to sell some of these great products and offer them to the population is because people have mortgages, children, et cetera, legacy, you name it, right? And so these products are still super relevant, as been highlighted today and just highlighted moments ago by Steve, where this is still a big thing. And I like to say, I'll tell everybody here, the industry hasn't changed their images. Steve actually commented on images, which was kind of interesting. But what we see is still like that core of getting to people's lives and looking to protect them is still at the heart of the life and annuity business. But yet change is really, really coming. I think one thing to highlight is we do see life and annuity carriers starting to add what you would call value-added digital services. So what's happening is, whether that's the ability to store all your information in one place, we see several with more of a trust and will element. So looking at adding new, call it features. These are actually, in these cases, digital features. So what you call like low cost, like services to enable, and these are digital enabled. So, right, they're low cost to the insurer. But the ability to bring them in and start taking care of them earlier is a big area that we see coming, and we see more and more looking to say, how can I serve, besides selling someone this product and disappearing, how can I offer kind of a lifetime here? Now, I will comment, take a quick turn and say, innovation is really happening across the insurance space in general. So I'm sure many of you are familiar with Lemonade, Metro Mile, and even a company called Beam here. But we see technology, breathing in and actually dramatically kind of changing the insurance outlook and the way the customer either interacts, whether it's Lemonade, specifically like focused on digital and in the phone for all practical purposes. And then you have like the Metro Mile or Route, which I guess is planning to go public, which is looking at, like pay or does pay per mile as well as behavior based. And then Beam, even, who is a new type of connected digital plan that legitimately can, track and benefit you or offer rewards for, your actual brushing on a, multiple times a day. So this is not, the things I'm going to review today is not some kind of anomaly. Life and annuity, the life and annuity business, and I will say the annuity business seems to be even more dramatically behind, in my opinion. But ultimately, we're still very much functioning the same way. Yet, the average, this is kind of crazy when you really look at it, but the average person has 15 devices connected to like a telematic style, device. So, whether it's your car, the things you plug in your house, your watch, you name it, average has 15 devices. We spend 5.4 hours a day looking or with our mobile device. I'm sure younger people could be driving this up, yet my 89-year-old grandmother on the other side actually pretty much largely uses Facebook, Instagram, and a wide range of other things to talk to me. And she's obviously retired and thus has even more time to do that. And then, you just see kind of mass smartphone adoption. So what I'm highlighting here is kind of what's building into the life and annuities opportunity to meet these people where they're at, to affect them on the positive. And, you look at like insurance in general, right? Smartwatches, connected cars, water detection, brushing teeth. Insurance is now has the opportunity to be more connected, and that's what I think you'll see as we dive into some of the cases here. I think that the reality of where the opportunity lies and what is kind of being built right now is the amount of data being generated. I will admit to you that, like I think I always say, the banking sector is about 12 to 15 years ahead of life and annuity. The property and casualty sector on data is, about 10 years ahead. And really, like the reason why my job is so interesting and so great right now is that life and annuity carriers are just getting into kind of the weeds here and the enablement of creating these vast amounts of data on an ongoing basis to basically start building new products. So what you see here is the formal turn I'm going to make. The life insurance industry is looking, I will just tell everyone here, is looking at physical, financial, and mental health, that holistic view of what is life insurance, why do people buy it, and how do we bring that together in a digital way to benefit that customer, to benefit us as an industry, and ultimately, and I would say to change the perception on some level of maybe where areas where the population has us wrong, right? Whether they think we're too expensive, whether they're looking at, we're high, all we care about is sales and sending that bill once a year. Because mind you, that's about how we've been treating some of the population. And I think that's where we see the opportunity to evolve here. I thought, my mandate was to educate, all of you today on what we're seeing. Many of you may be more educated than me here outside of what I focus on, but I'm going to take you through a little journey of for example, John Hancock recently released a diabetes focused life insurance policy. So really being able to connect, they're using devices. It's called Aspire, and they're using devices, and if you adhere to kind of your diabetes regimen, they're willing, able, and excited to serve you as a customer. And I think this is where you'll see a lot of it, the merging of kind of risk, and those that take care of themselves are thus, very, very likely to do very well, and those that do not. I think I see a common theme around longevity there, which many of you on the call know much better than I. John Hancock also has released, and this is actually the longest standing product in the market in this area. It's called Vitality, in which is looking at, saving people, money and offering rewards for healthier living, where, you have a rider that sits on top and allows up to, it says here a 15% annual premium savings through basically reporting on your health information. You have to get you report your real-time, IoT information, et cetera, off your Apple Watch. And then, they ask you yearly updates on your health. And I'm not totally sure where they're at with, if they're asking you, I guess to get your maximum benefit, I think you have to get a physical. So the next to highlight here, which is Principal Financial, and which they also are bringing in lifestyle and financial fitness to their policyholders, to their life customers, to encourage them to live within their, to encourage their health, which is a common theme throughout that we see, but also to bring in financial fitness as kind of another benefit. I think the thing I'll highlight here is that I have seen us as an industry asking, like, what is it that life and annuity products really seek to accomplish? And I think behind the scenes, we can talk about all the financial levels, but it's always, it's about your life, right? So your health, your finances, and ultimately that financial security, your mental. So it's funny, this conference really does encompass that like the core behind these products are actually, unfortunately or fortunately, the reality is death is a part of all of our life. So you have this, that's a part of the product, but then, you know, the feeling that maybe they offer some kind of financial benefit, as well as they, you know, us as an industry wants to promote that. And then thirdly, obviously, the financial security, knowing that either you're taken care of or that your loved ones. So what Principal does is they, you know, watch your progress and encourage you to kind of hit certain goals, and they will reward you actually as you meet those challenges, or as you know, kind of, I'll call it, push yourself to live a happier, healthier life. And so they have some great reviews on that. Most of these things that I go over today are actually, I'll call them, they're not core to like their day-to-day, but they're rising. And so you can see here that they reward them with gift cards, which is pretty common. Another company, and I tried to bring in kind of some outsider ones that are kind of emerging, is, you know, Sprout here, which is all about rewarding your life choices. So, you know, you'll see a common theme of what's available today, such as like movement is a big avenue that, you know, I call it, it's low-hanging fruit. It's one of the data points they can gather. Although my opinion on the industry, because I've been looking at movement for a long time, is that the industry isn't complete. Actuaries and underwriters, in a sense, are not at the point where, you know, on movement alone, they categorize that. Sleep, I will tell you, I guess, you know, I'll admit to you, I have sleep apnea, and it's super interesting to see already. I've just been diagnosed. It's super interesting to see how my life insurance, as I've applied for some since then, because I'm a big life insurance buyer as I study, you know, has been affected. Emotional health, right? So this is an interesting one in which they're using a lot of different surveys and or kind of, you know, analysis tools to ask people how they're doing, how they feel, very much almost like my sleep apnea app does, where it says, you know, how do you feel? Are you tired today? To gauge that. Nutrition's another one. See, when you look at some of these, what you start to get away from is their ability to track it on a full level. Actually, I went through this process here with this company, and it was interesting the way they looked at, it seemed to understand my nutrition. They asked me questions, but it seemed to be, you know, how educated I was on nutrition, which was quite interesting. Don't know if there's a correlation. Well, there must be a correlation there, but I could answer all the right questions, but I did go get a big burrito yesterday, so I can't tell you that I followed it. And then balance, holistically, they look like any kind of underwriting or actuarial process. They look at the overall view to see, you know, where things are at there, and you know, does this person kind of, you know, I call it, will the actuary underwriter kind of assess that holistically, you know, they're a safe bet. Take a turn here to State Farm. They have a program called Life Enhanced, in which they're looking at that whole holistic view of that person. You know, State Farm is one of the largest life insurance providers in North America, with, you know, I think 9 million or so. So super interesting to see how they're building their program, in which they're looking at physical, emotional, social, and financial. I thought this was, you know, in regard to the conference today, as well as the kind of our session specifically, I thought this was well aligned with that, in which they're looking to educate, reward, and then, you know, basically bring together kind of what a holistic, you know, life insurance experience and life insurance company wants to be about. And really look at, I mean, once again, they're bringing it back. This is still the program, Prepare, Preserve, Protect, in a way that they can bring us together. Look, and mind you, this is all through digital means. They haven't changed from our agent model or anything of that nature, but rather offering digital, you know, the average person, you know, is definitely looking at that phone more. So how they're going to support that person along that journey. So that's an overview kind of quite a few use cases in the life space. I will tell you, I haven't seen much in the annuity space in particular. I think that's just something I've been working to see, but have not. We see people selling them a little differently at times. There's digital sales online, but not a bunch of product changes there to date. But as I take a turn, I think it's interesting to look at what I'll call it what I think's next. I think as we look at that first stab into like rewarding, et cetera, I think now the big question is how are interventions going to play a role, medication at, you know, adherence and compliance. I think Vitality had Aspire has an aspect of that to where you kind of have to adhere by the program. Smoking programs where I was funny. One of my friends works at a company called Carrot, which is about there's quite a few programs non-related to the insurer, but how are they going to intervene when someone is a smoker? How much continue they will to change, you know, kind of that risk profile. You see diabetes here on the bottom, but ultimately, will they bring in a laundry list of ways in which they can basically change their risk factor profile? There's profit there, but also, and maybe more importantly, there's a way of showing someone you care throughout the life of that policy that you sold. I thought it would be interesting to kind of take a turn and show you what I've been thinking about actually for years as I've been building things. I thought this was a conference to talk about the turning of where possibly with connected devices, aggregation, and real-time exchanges, real-time or dynamic risk can be shown. And so we all know there's certain forces weighing on mortality. I'd say many people on this call know it much better than myself. I find it interesting, you know, the life insurance industry looks at several of those. I think they obviously do a great job to understand that risk, but there's a new, I think there's new capabilities to track this in a more you know, kind of a real-time fashion, actually to look at books of business. And that's really based on the ability to collect data in real time, whether that's EHR data, health records, devices, you know, you have things like Higgy stations in many, you know, shops, to bring that data to a central location. So to make my point as I kind of around the corner here for the close, I thought it's interesting to look at myself. On the left, I actually got married as a rather young man, and the truth is I looked a lot better. My smile even looked better, I feel like. My wife is still wonderful. I've had a daughter since then, but I think why I show you this is, if you notice on the left here, I'm actually 23 years old, and you know, that's when I bought my life insurance policy when I got married, and they had my survival probability and my curve down to what they thought it to be. Over time, you know, and once again, my BMI was at X pace, but then now, years later, right, you can see on the left-hand side, I was about 226 pounds. I'm roughly about that now. And now my data is a little different, right? This is all collected through real-time devices, mind you. My blood pressure before, you can see here 115, 113, my blood pressure after. I know this is sad for some of you to watch, but this is, maybe in some ways, I'm a good indicator of the world we live in. And so what I'm showing you is actually in the system where we're able to register this and see like, okay, well, this is starting to change. Glucose, right? You see through a EHR poll. We're actually using a company called Human API, but we can pull in, this is my information here. And you see before here, it was great. And all of a sudden I start to look a little pre-diabetic. And overall, you know, there's all these given mortality or longevity factors weighing on me. And unfortunately, you know, to date, I've behaved very much like either they expected me to on that curve or not. And so, you know, my life expectancy at that point, I was you know, an athletic young individual in great health. And then over time, sadly, you know, I started smoking cigars, doing some, you know, and all of a sudden, you know, here I am, you know, with my life expectancy shrinking. What we see that potentially the life and annuity space will offer is companies the ability to review kind of their assumptions in their curve and watch people stray in real time, so that they can assess their books of business, but also try to counteract that with interventions. and then ultimately they can actually see these books of business move, whether there's, whether someone's right on point or they have drift based on these individuals' behavior, and or opportunities to either sell off books or analyze their books and see that they've actualized risk appropriately. We see these as kind of deep underlying capabilities inside of the business here. So that is my overview. Hopefully I've left you with some critical thoughts here around where we see the space going. I truly appreciate your time, and you can always reach out and ask, and I'm available for questions here.
Okay, thanks so much, Dustin. Absolutely fantastic. I love when we get sort of a theoretical view and then move on to more practical view and see what's happening. Before we end the conference, I just wanted to ask each of you actually the same question if possible, because I'd love to hear both your views, and then we'll try to end on time. There have been a lot of studies. We talked about that people are not saving enough for retirement and possibly using insurance enough. And there have been a lot of studies that say that the reason for this, or one of the major reasons, is a lack of trust in our institutions. And I think, Steve, you talked about it a little bit. You talked about, showing hands, holding hands and walking on the beach, which is not practical for a lot of people. So they really don't have the trust that that's the product for them and that's what they should be doing. So there is a lack of trust in the industry. So Steve, I'll just ask you what can be done about that. And Dustin, I'll ask you the same question a little bit differently. We'll go with Steve first. And when he's done, you can go and just say, what can technology do to overcome that lack of trust in the industry? So Steve first, from a theoretical point.
Okay, Ronnie, thanks. And the question really gets at the heart of what we debate endlessly at the Center on Longevity, is how could we improve decision-making? So I can't tell you a verified answer on that one from research, at least. I can speculate. I think trust in financial institutions is one factor, but it's probably not even close to the most important factors. And I think it's more a matter of economics. Do people have enough money to save or to buy insurance? And also, here's my own little pet theory, is that advertisers have gotten very, very good at persuading you to part with your money and buy lots of stuff. And so I think that they are ahead of financial institutions in getting people to make more responsible decisions. And so that's my speculation as to one of the factors, is that it's just people are bombarded with very persuasive ways to spend their money on stuff. And they just don't think long term. And so that's my own little pet theory, but I can't claim that's the answer. So that's it for the moment.
Thanks.
Yeah, I think, actually bringing the data forward, I think, and that is a big opportunity with digital. The insurers, I feel like the average consumer doesn't feel like the information on these products, and we see this, is well understood. So it does seem like kind of transparency and maybe better education in this process is a huge opportunity. So we can't, it's not going to be a one size fits all. You'd say, like I said, you build an education site and all of a sudden no one comes there. However, with digital, it seems as though a lot of digital capabilities, it does seem as though there's a big opportunity to kind of bring that all forward. And also guide a product versus just someone selling it and then disappearing and paying a bill. I think there's a great opportunity here to walk alongside someone, as we want to do and claim to do, to build that trust back. Anytime people sell things, I think you have different incentives. And so the challenge is how we rebuild that trust I actually think data and transparency amongst these companies, actually, we have a big opportunity to do it. It's a huge challenge, though.
Well, again, thank you very much. And once again, thank you to Prudential for sponsoring the Geneva Association Health and Aging Conference 2020, brought to you virtually. We had great speakers today, kicking off with Jad Aris, the Managing Director of the Geneva Association, Yanela Frias, just absolutely fantastic as President Retirement at Prudential. And then we went through the sessions, the first two sessions with Richard, David, and Andrew in the first session, and then of course Steve and Dustin just finished off. Tomorrow we start off again. It's for you guys on the West Coast. It's 6 o'clock in the morning. Sorry about that. On the East Coast of the U.S., so it starts off at 9 o'clock. If you're at Atlantic time, maybe Bermuda or some places in Canada, it's 10 o'clock. In the UK, you're there at 1 o'clock, and here in Central Europe, we are at 2 o'clock. And of course, if you're in Asia, depending on where you are, it could be 10 o'clock at night. So thank you if you're joining us that late at night. So again, please join us tomorrow for great sessions on the reactive to proactive care, and also the view from above with two top CEOs in the industry. Again, thanks Prudential, and thank you for staying with us into the evening if you're in Europe, and to lunchtime if you're in the United States. And we look forward to seeing you tomorrow. Thanks very much.